What is up, San Diego Virtual Pain Summit? I am so excited to be here. My name is Jason Silvernail. We're going to talk about difficult conversations and patient noncompliance. We're going to get into all sorts of really interesting things that I'm hopeful that you will really like and that will give you practical tools that you can apply tomorrow toward making some of these things smoother for both you and for other people. At the title slide here, you can see all the different little icons of where I am in social media. If you're on Facebook, Twitter, Instagram, YouTube, LinkedIn, TikTok, find me, like and share and interact with me, and let's talk some more about these things. And I look forward to hearing your questions and comments in the Q&A at the end. So let's get started with what is probably the most exciting slide, the disclaimer slide. So I'm here as Dr. Silvernail, not as Colonel Silvernail. So I'm a career military officer in the U.S. Army. So the things that we talk about here, the views expressed, are those of me and do not reflect the official policy or position of the Department of the Army, the Department of the Defense, or the U.S. government. That is the disclaimer slide. And then slightly more exciting is the disclosure slide, where I tell you I have no financial relationships to disclose. I would really like some financial relationships to disclose. Nobody goes into the Army to get rich, and that's true of me too. So maybe someday I'll have something to disclose, but right now I just don't. So let's jump into it, and I'm going to start off with the bad news. So here's the bad news here is that everything is your fault. So the bad news is that noncompliance, in my view, expresses the 100% wrong attitude about patient adherence to plans of care, and adherence is the word I want you to use and not noncompliance. When patients don't follow through on their program, it's usually your fault. It's not the client's fault. And if you are stuck in difficult interactions with other people, it is usually because you have failed to confront issues, failed to maintain boundaries, and failed to set appropriate expectations. And that's the bad news, is that everything I'm talking about today is your fault. And when I say you, I mean me. It's my fault too when I'm there. But the good news is everything is also your responsibility. That's the beauty of accountability. So learning to approach care adherence for your clients and patients through their view restores your connection to the pleasure and the joy of serving others instead of bossing them around. You can improve adherence to your plan by demonstrating some key patient-centered behaviors that I will list out for you and that you can apply tomorrow and that are in fact teachable. And you can learn to proactively manage difficult interactions with other people, to include patients, clients, colleagues, supervisors, and even your friends and family, in order to improve both your experience and theirs. And again, I will give you practical tools that you can apply tomorrow that will help you with this. So really what I want to talk about today is I want to talk about difficult conversations. And that's really what this discussion is like. There's a book cover on the screen there for you to look at. And so I read this book many years ago, and I really enjoyed it. Of all the things that I've read and training that I've had about interacting with people and dealing with difficulty, I think this is a really good, easy read, and it's highly recommended. So why are we having this talk? Why am I delivering this talk to you? I'll tell you why. Because people tell me often that they have patients or clients who argue or disagree about treatments. They have colleagues that are uncooperative or difficult. They're angry at work. Clinicians tell me they're frustrated that patients don't follow through on their treatment plans. And sometimes they've even said they don't feel the patients want to get better if they don't follow direction. This is one thing I've heard a lot. I can't want to get better more than you do, or I can't want it more than you do, or words to that effect, right? So that's very frustrating for people. And I want to help you sort this out. I want to help people sort these kinds of issues out. So in order to do that, we really need to just talk about difficult conversations, and that's what we'll do today. So the first thing that I want to talk about when we get to this is that people feel that there's sort of professional boundary concern. They say, oh, what about my scope of practice? This isn't my job. I'm not trained for this. This sounds like some psychology stuff. I'm not a psychologist or a counselor. I'm not here to walk people through that kind of stuff. I'm just here to do rehab or massage or fitness or whatever, right? Well, here's the thing. So working with other people and developing a relationship based on mutual respect, where you are respecting each other's boundaries and successfully working together to achieve the goal, whatever that goal is absolutely your scope of practice, no matter what your job is. That is our whole job. So when we think about that's not my job to talk to people, please best believe it most certainly is your job, as it is mine. So we've got to work with people and find ways to help get along cooperatively and be able to accomplish things regardless of what your background is, rehabilitation or medicine or fitness or massage or whatever it is, right? Some things people say, like, I'm not trained about how to do this. I said, well, maybe not a lot, but a lot of these things are basic, and they're about human interaction, and they're teachable. So I'm not going to teach you today how to make a psychiatric or psychological diagnosis. I'm not going to do that. I'm not going to teach you how to provide behavioral health care to someone with a psychiatric or psychological diagnosis, right? That's not what this is about, right? This is about interacting with people and helping them adhere to programs that will help them get better, and how you can proactively manage your behavior when you interact with other people, right? So the question then comes, okay, if boundary is not such an issue, like, why should we listen to you? You're not a psychologist. Well, you're right. I'm not a psychologist. I'm not a life coach either. I'm not in the motivational interviewing network of trainers. But what I can do is tell you a little bit about what my background is and how I think it can help. So I've been in medicine for 20 years. I'm a career military officer. I've been in the military for almost 30 years. And a big part of my job is dealing with interpersonal interaction problems, helping people gel together as a team and accomplish goals, and diffusing and handling interpersonal conflict is a big part of my job. And it is on a recurrent basis. So I think I'm a good person to offer you some feedback and advice in this area. And I'm going to focus away from sort of big picture theoretical things, and I'm going to focus directly on actionable skills and behaviors that you can put into practice tomorrow to make this easier, both for yourself and for others. So I want to start by talking about just this term non-compliance, right? So as I talked about before, I really don't like the word non-compliance, and I'm hoping to convince you today that that's the wrong word for you to use if you're still using it. So non-compliance sounds like a law enforcement term, right? Now, it sounds like something a law enforcement officer would reference when they're interacting with someone else, right? They want compliance, right? Here's the deal. If we're in a helping profession, if we're in a service profession, and I'm guessing you're in one of the two, maybe even both, you're not looking for compliance. You're looking for cooperation. And the only way to get cooperation is to move past this idea that I boss you around and move toward the idea of we need to work together and collaborate to build something that will work, right? So the non-compliance mindset is the first thing that we need to talk about and get rid of. So when we think about issues about non-compliance and coming together, really what we're thinking about is following instructions. And I know what you might be thinking. Isn't it easy to do the right thing? Don't we just have to tell people what the right answer is or what the right thing to do, and won't they just do it on their own? Well, it turns out a little bit more complicated than that. The question for us is, why don't our clients or patients do what we ask them to do? And so I think some people say, well, what you really need to do is you need to create a presentation about how to deal with difficult patients. Sometimes clinicians will say this to me, right? These patients are difficult, and they don't follow instructions, and they don't do their home program, they don't implement their exercise programs, they don't follow along with their conditioning program, and I don't know how to deal with them. You need to teach people about how to deal with difficult patients. I'm kind of listening to this as people talk to me about it. And I thought maybe I could do that. But then I thought, no, that's not the right thing. Really what they wanted me to do is create this presentation. How to deal with patients when you are difficult. Because if you think that the people you deal with, your clients and patients, often are deliberately being difficult and uncooperative, I have news for you. You are the problem, not them, right? So I really thought about how to create a presentation that says how to deal with patients when you're difficult, because that's really what this is about. And we need to be able to move past that concept and toward a more cooperative partnership with their patients and clients. So when I think about why people don't do what we ask them to do, I think it's mostly our fault, in fact. It's usually not their fault at all, it's mostly ours. And when I think about why they don't follow through on a program, I think about 4 themes of reasons why that doesn't happen. Now, I don't mean that these are 4 very specific reasons. Don't hear what I'm not saying. I'm not saying that in all the world there are no other reasons but these 4. I'm saying that these are themes or topic areas that we might consider for our patients and clients. So maybe they didn't follow through because your advice didn't help. or it wasn't relevant to their problem. Maybe it wasn't feasible for them in their life, or, and this is very rare, they want to really continue in the patient role. We'll talk about things like malingering and secondary gain in just a few minutes. So the first is your advice didn't help, right? So when a patient comes back to me and I find that they are not any better, this is what I think about. And if I gave them advice and they tried to implement it and it didn't work, why would they continue doing it? Only a crazy person would continue to do what wasn't working, right? So when they come back and they report that they're not any better, the first thing I think about is the idea of subjective versus objective improvement. Many times patients will come back to me and say they don't feel like they're any better, but then their objective measures, their function, their movement, their self-report score is actually quite a bit better than the last time I saw them. And so this is an opportunity for me to help people see and show them the improvement that they've made that they may not be able to see. So that's the first one. So generally, now my line of work is physical rehabilitation. So in conservative musculoskeletal care, most conditions get better with time and evidence-based treatment. So if it's not getting better, my first thought is maybe I have a diagnosis problem. Maybe I'm working at the wrong thing to try to fix. Somebody came in with shoulder pain and we gave them some really good evidence-based shoulder rehabilitation and they're not any better. One of the first things that's in my mind is maybe this isn't a shoulder problem. Maybe it's a problem somewhere else. Maybe this is referred pain from their neck, which is actually quite common, right? So maybe I missed the diagnosis. That's one. And the other is maybe I have a dosing problem. Maybe what I gave them was appropriate. I just didn't give them enough of a dose to be successful. Maybe I overdosed them and they got a little worse, or maybe I underdosed them and they're not doing enough load or activity in order to improve. And so those are some of the things I think about when patients come back to me and say that my advice didn't help or they're not improving. But any patient or any of us who's doing something and it isn't meeting our goals, we'll stop doing that thing. And that's just a natural thing. So the first theme is your advice didn't help. The second theme is maybe the advice wasn't relevant to them. It needs to fit the patient goals. We have to make sure that what the patient thinks is wrong and what I think is wrong line up. It doesn't have to be exact, but it has to be pretty close. We'll talk a little bit about the chief complaint, and I think it's important for all of us to think our patients and clients are not going to go home and spend their own personal time doing things that we think are important. They're only going to be doing things that they think are important. And that's an important mental step for us to make. Another thing is our advice wasn't feasible, right? So maybe it wasn't possible for them to execute our advice. They have environmental challenges or an ability to actually follow through on the program. So if a patient or client lives in an area that is not physically safe for them, giving them a walking program, if they have no place to walk or no place to walk that is safe, that doesn't make much sense. That's a program that's not feasible, right? Giving someone a weight training based rehabilitation program. Now, strength exercises are very popular right now to prescribe for musculoskeletal problems, and I think they are generally pretty evidence based and a good idea. But sometimes the prescriptions given are based on gym based weight training routines, and unless we're dealing with a small percentage of our patients who are regular gym goers and like going to the gym and lifting, then chances are that it's not a prescription that's going to be feasible for that person. One way to assess this is to have them do whatever the home program is in the clinic with you. Now, you can't always do that for every plan that you build, but for when you can, it allows you to determine whether or not the exercise program is feasible for the patient to execute and whether it actually helps them or moves them forward with their disorder, right? And so your advice needs to be feasible for the patient. And if it's not, then that's probably our fault, right? And the last is the patient might want to maintain the patient role. This is the concept of malingering or secondary gain. Now look, let's put to bed some of these concepts and ideas. Let's have some real talk about secondary gain and malingering and all that stuff right now, you and me. So I practice in the Department of Defense, and I have for the last 20 years. And in the Department of Defense, people get monetary benefit for being assigned a percentage of disability. And they get relief from job requirements if I sign a work excusal form and I sign in the doctor book, right? Now, that's an environment in which you would think people are motivated to maybe complain a little more than they should in order to get out of something or to get some money. Maybe some people think that that's the case. But I have to tell you, in over 20 years of medical practice in the Department of Defense, I have maybe seen this 3 times, maybe. And the third one I'm not even sure of, right? It is not just rare, it's exceedingly rare. It's also impossible to reliably spot. And I don't want to put myself in the role of trying to figure out whether someone has a real problem or not, right? We'll talk about that a little bit more in the future, but that's not the appropriate role for me to have in the clinic. I'm trying to do my best for every patient that comes to see me, and if I'm not able to help them, my responsibility is to move them on to another option, right? But people who want to maintain the patient role are exceedingly rare in our system. So they might be rare, but then it brings up this question of what about secondary gain? Now here, some clinicians talk about this a lot, and I'm going to be straight with you. I have never heard a clinician talk a lot about secondary gain who was not also angry at their patients, unhappy, and burnt out at work. And so when I hear this from a clinician, it's usually not a good sign. So here's what secondary gain means if you look it up somewhere, right? You can see the definition on the screen there. So let's talk about some examples of secondary gain. They might be monetary compensation, right, through the legal system, or government benefits or corporate compensation, something like that. They might be relief from social or work responsibilities, like a sick slip or work excusal. There might be some interpersonal regard or sympathy that they might try to be gathered as an illness sufferer, or they might derive a sense of control by directing the actions of others through medical treatment. Now, all of these are what you will find if you go to look up what secondary gain is about, right? So it's worth asking ourselves, what are you really getting? When we talk about gain, what are we really gaining here? Are we talking about money? The monetary compensation people get obviously varies based on what country they're in, what corporation they work for, or what their setting is. Does any of us think that that is a lot of money? I encourage you to look that up and do your own research. So the monetary compensation for disability and illness, almost no matter where you go, is not that much money. Folks, it's peanuts, right? It's peanuts. Nobody is sitting back getting rich on disability compensation. How about relief from responsibilities, right? So if you don't have to go to work, isn't that a good thing? Isn't it good that you are relieved from work? Isn't that a secondary gain factor? Well, you get hardly any of that from a disability claim. You just replacing your work with medical visits and paperwork. That doesn't sound like a big deal. How about sympathy? Are people who are sick really getting a lot of sympathy from other people? I don't think they're getting sympathy. Sometimes they might get pity, and that doesn't feel good. So if you know, or you yourself have had a serious illness or injury and been in that role, you know that is not a fun place to be, right? How about this idea about controlling other people through the medical system? Well, I got to tell you, like everybody else in the medical system, I get paid for going to work and taking care of people. Like there's no special power involved in asking me to do my job, right? So when we really look at this idea of secondary gain, we pull it apart. There's really not a whole lot of gain to be had, is there? Right? So it's also important to realize secondary gain, that's only half the equation. There's a whole other half of the equation. And what is that? It's primary loss. We're all good about talking about secondary gain. What about the primary losses? What do you lose if you are chronically sick or injured, right? Well, you lose your income or family responsibility. You lose your freedom from having to coordinate visits and paperwork and to, fill out all this paperwork and argue with somebody, whether it's a corporation or a government agency, to prove that you are really sick and injured in order to be able to follow through and get the care you need. That's a lot of fun, right? You get to lose your independent role in family and society. And often you lose the sense of appreciation or dignity for others for the role that you serve for them as somebody who is serving and helping other people. Those sound like some pretty heavy losses for not very much gain, right? And so because of that, I'm going to just propose you a trade. Let's make a trade, shall we? We are going to trade one thing for another. We are going to trade our secondary gains for our primary losses. Now let's put them up on the screen right now. You can see it right now. And let's look at what you lose and what you gain. And I want you to tell me if you think this is a good trade. If you lose your primary income and responsibility, your independent role, appreciation from others, respect and dignity for doing what you do, and your freedom to pursue your life on your own terms, you're going to give all that up for the peanuts amount of disability or compensation money and the joy of coordinating multiple medical visits and filling out all this paperwork to prove to other people that you're sick, losing the role that you have in your family and society, loss of control of your own life. That's what you have to give up. Who would make that trade? Would you make that trade? I know I wouldn't. It is a terrible trade. But it's not just that it's a bad trade. There's more. Secondary gain is just another term for blaming the patient. So please don't do it. And what's worse is that secondary gain actually does something else independent of patients. Secondary gain, the concept, is a crutch for us in the medical system. We didn't invent it for the patients. We invented it for ourselves, to make ourselves feel better, to avoid facing our own failures, to help other people. The question is, who benefits from secondary gain? We do. That's what secondary gain is about. It's about making us feel better in medicine. And it is therefore toxic and damaging to our relationship and care for patients. It actually puts us in the situation of feeling like we need to play Nancy Drew and the Hardy Boys, searching out and being an investigator to try to see who's got real problem and who doesn't. Because if we can tell ourselves this person doesn't have a real problem, therefore we can feel better for our inability to help them, right? Secondary gain is a crutch for us. So here's our big picture 4 themes of people who have difficulty following through with your instructions or plan, and here's the concepts of why. Your advice didn't help, it wasn't relevant, it wasn't feasible, or those very few people who want to continue in the patient role. And we've talked a lot about secondary gain, we talked about primary loss, we talked about noncompliance, we talked about malingering. I hope you'll think carefully about this, and I hope that some of this resonates with you. Because really, it's easier for people to adhere if you're working on a goal that they value and that you are seeing the problem through their point of view. And if the plan that you've put in place is actually feasible for them personally. But sometimes, despite everyone's best efforts, there's some conflict. Now, who might you have conflict with? It might be with your clients or patients. It might be with work colleagues or supervisors. Or it might be other people, maybe even your family and friends. And let's talk to Tim today about a framework you can use to enter a difficult conversation and improve your experience and the people that you're in it with, right? And so the 4-step system works like this. Number 1, you have to understand your own mental posture when you enter a difficult conversation. Number 2, you have to learn to move towards the problem rather than away from it. Number 3 is you have to learn to recognize and respond to emotions that make difficult conversations hard. And you've got to find a way to pivot to moving forward together with that person. So let's talk for a minute about your mental posture. I got a quote up on the screen that that I used many years ago that people seem to like, and I'm going to repeat it here. When I freed myself from the responsibility for the outcome of the clinical encounter, something interesting happened. I freed my patients from blame also. So your mental posture as you enter is that of someone who is here to be a helper, right? Whether you are in rehabilitation or massage or fitness or whatever your service business is, right? Like you could be making cinnamon rolls at the mall, and your mental posture needs to be, I'm here to help someone, right? Now, when you put yourself in the right mental frame of mind, the whole rest of the conversation has the potential to go much better for you. And when you think about your mental posture, you think about what your job is. Like if you get into a conflict with someone at work, it's worth thinking about. What's your job here? Is it to be right? Is it to heal someone? Is it to not let that person get away with doing whatever it is they're doing? Is it to have your way? I don't think your job is any of those things, right? Your mental posture in your job is to put yourself in the role of being in service or help to someone else. And it's that mental posture, it's that sense of job role that you have when you enter the conversation that will make the rest of it go much more smoothly. Because really, it's not just up to me whether someone gets better or not. If I think about a positive clinical outcome, it's really an equation, right? And I've got the variables for the equation on the screen there. Now, a positive clinical outcome has to do with luck, the genetics of the patient, the social determinants of health. What do I mean by social determinants of health? Someone's socioeconomic background or where they live, and the social or cultural things that affect their health, right? Their environment, the nature of their disorder or problem, the actions the patient takes, and the action I take. So wait a second, it's a lot of variables. And I'm only responsible for one of those variables. Here's the deal. I'm not actually in charge of making people better. I'm not in charge of that. I'm in charge of making my variable of clinical care absolutely as good as it can be. And the other variables are outside my control, right? And our mental posture needs to reflect that as we enter a conversation with people. The second thing I want you to think about is I want you to think about moving towards the problem. Now, if you've got a military background, you might be familiar with this concept or idea, is that the only way out of this difficult situation is through. Turning around and going back, not an option. Avoidance, not helpful. We need to learn to move toward the problem by pushing through the difficulty that we have with someone and doing it in a way that will improve our experience and theirs. So I need you to know it's natural when conversations get difficult for people to want to pull back or avoid something. That is a natural response to a difficult conversation. Unfortunately, it tends to perpetuate the cycle back and forth of difficulty and doesn't solve the problem, right? So patients or clients who are upset, they are used to people pulling away from them, right? They're used to people not listening and pulling away. And those few people that you run into in life who are genuinely difficult, and there are some of those people out there, they count on your reluctance to engage as a way to keep you from enforcing and observing important boundaries with them. And so for all of these reasons, one of our first goals when we sense difficulty is to move towards the problem rather than away. So one of the expressions we have in self-defense is, if you can make them talk, you can make them walk, right? Now, the goal in self-defense is for things to not turn physical, right? So if I end up getting into a fight with someone, that's not a good thing for my ability to defend myself. That's a bad thing, right? I have, at some level, I have failed if I have to have a physical confrontation. My goal is to always avoid that, right? So if I can sense that we're getting close to that physical part, if I can sense that and I can keep talking and I can keep the person that I'm worried about talking to me, the chances are good that we can resolve it verbally and he can walk. In other words, we can end the encounter without it getting physical. Now, what does that have to do with what you do in the clinic or in the gym, right? Well, if you can engage with someone and talk and interact with them and move towards them, chances are good that things will not get worse in some other way, a complaint or anything like that, right? You want to move towards the problem and stay engaged with someone during this difficult conversation. Now, I know that is not what your typical intuition will be. And you need to learn to push through that intuition and move towards the problem. So the question for us is, what is it about a conversation that makes it difficult, right? Well, it's the presence of emotions. Emotions make conversations hard, right? So in a medical context, seeing someone else in pain is not easy. It's easy when you have emotions around to take things personally. And I want you to know that meaning and emphasis is more important than exact words. And when we have high stakes, and health and medical care are high stakes, there's a sense of high anxiety in interactions too. And it's the presence of these difficult emotions that make conversations hard. I'm going to teach you a system to respond to emotions in a way that will help you understand yourself and the other person and help you negotiate this in a much more successful way. And the system I'm going to teach you is called ANLOS. The AN comes first. It's acknowledge or apologize. Name the emotion you see. And that first initial movement, that AN, it helps lower the temperature and helps people feel heard. And then you move on to legitimization, openness, and support. And I have some example phrases that help you understand what these terms mean. So we're going to go into detail on the ANLOS system right now. And I'm going to work you through a couple of examples, and then we're going to show common pitfalls and common best practices in just a minute. So you enter into a difficult conversation. Your first response should be AN. The A is acknowledge and apologize. Acknowledgement means to acknowledge the situation is difficult or acknowledge the person as they are. That helps them feel heard and it lowers the temperature. You can sometimes also apologize. Now, you don't want to apologize or take responsibility for something that's not your responsibility to take, but you can apologize for their experience or for the situation in a way that doesn't put yourself on the line and make it personal for you. So that's what acknowledge and apologize is. That's A. And then is N, and the N is for naming. We are going to name the emotion that you see. By naming the emotion that you see, you are directly talking about what isn't being said. In difficult conversations, people talk about everything but the emotions that they're feeling. And this process of naming helps you cut right to the center of the issue. Now, I think the best example I can think of AN is I saw a video many years ago. Now, I don't have children, but this video is of a mother and her son, and the son is like maybe 2 years old, and he's clutching a Spider-Man doll, and they're having an argument about going to school. And that really resonated with me because I was 2 years old, and I had a Spider-Man doll, and I did not want to go to school either. And the video went like this. The child is holding onto the doll really, really hard, and he's yelling at his mom, "I want Spider-Man!" And the mother said, "Now come on, Billy, it's time for school, we gotta get ready." And then he would yell over top of her, "I want Spider-Man!" And she would say, "No, come on, Billy, we gotta put the doll away, and it's time for you to go to school." And he would just yell, "I want Spider-Man," over and over and over, right? Clearly, we're not getting anywhere, right? And then after about 3 or 4 of those, the mother kind of gets quiet. And then she leans in and she says loudly, not yelling, but loudly, "You want Spider-Man," really in that kind of forceful tone to her son. And the child goes, "Yeah." And then all of a sudden, the whole rest of the encounter went smoothly. Now I thought, oh my gosh, what a perfect example of acknowledge and name, right? So by talking back to the child about what he wanted, she was helping him feel heard. And when people feel heard, the temperature comes down in the interaction, right? People often are loud or more persistent or more boundary crossing if they feel that you're not listening to them. And that's that happens. If you're in the other room and you say something to your spouse or partner and they can't hear you, the natural thing is to say something louder, right? And if you're not heard, being loud is common. But the response of AN helps lower the temperature and helps the other party feel heard. And that sets the stage for the next movement, which is LOS, legitimization, openness, and support. Legitimization helps express that you are validating or affirming that the emotion that the other person feels is a normal and reasonable emotion in this situation, right? And openness shows that you're not afraid to hear more and discuss it. And support commits to working together to find a solution together instead of being at odds with each other. And that LOS is how you go from validating and helping people feel heard to actually solving the shared problem you have together. And when you move forward together, we need to return to a baseline interaction. We need to tackle problems that they value through their perspective and kind of leverage some of their own internal motivations. These are ways to move forward together in a therapeutic context. So when it comes to difficult conversations, we talked about 4 steps. We talked about understanding your own mental posture, to moving towards the problem. We talked about responding to the emotions that you see with the AN and LOS. And I talked about moving forward. And gosh, it really seems easy, doesn't it? Here's some examples that you've got. You can see some of the phrases. Here's some different ones. "Sorry, this is so difficult. It seems frustrating." See, we named the emotion. I don't blame you for feeling that way. Again, we're validating that emotion in this person. Let's work it out. We're in this together, right? Here's an example of a longer term AN and LOS. Look, hang on, I hear you. I'm sorry this isn't working out so far. So do you see my hands are up? I'm leaning forward. I have like a nice open and non-confrontational posture. I'm sorry this isn't working out so far. It seems like you're feeling frustrated. Is that right? Look, I'd be pretty frustrated too if I experienced what you just did. I want to know what you think I can do differently here. I want to work together on this, and I promise you I'll do my part to solve this problem. That's an example of AN and LOS. Gosh, it sounds easy when I do it that way, right? Doesn't it seem so simple when it's all on the screen? But of course, when you go to apply it in real life, it can get complicated. So let's talk about how to make this work. So first of all, there's some pitfalls in responding, some things I want you to not do, right? I don't want you to respond to literal meanings and argue the details. And I don't want you to take it personally or provide a knee-jerk validation or pandering for inappropriate things. And I'll talk about all those things. These are pitfalls, things I don't want you to do. The first one is I want you to not respond to the literal meaning of everything that is said, right? So the best example of this is the 10 out of 10 pain example, right? So some patients will say, oh yeah, the pain is 10 out of 10. Can't be worse, right? And they say it to you and they don't seem like they're in any distress as they are explaining to you that they have 10 out of 10 pain. Now, some clinicians, they'll respond to that literally, and they'll just become difficult about it. Well, if it's a 10 out of 10, it sounds like you have a major broken bone. We better take you to the emergency department, right? That's not helpful. That's a focus on the literal meanings. Remember, I used the example before. If you call out to your spouse or partner in one room and they can't hear you, it's natural to speak louder to try to reach them. When a patient tells me they have 10 out of 10 pain, what I'm hearing from them is they are not being heard by the medical system. And we are not meeting their needs. And so I don't focus on the literal meaning of 10 out of 10. I use that as an opportunity to understand the meaning behind what they say. Small errors of fact in emotional language, and remember, emotions are what makes conversations hard, are normal, right? It's also important that we not argue the details. What did or didn't happen immediately before the conflict, and who said what to whom, when. It can be tempting to dive into this and pull this apart and have an autopsy about who did what to whom, when. But I have to tell you, that never results in coming together and solving the problem. That's about blame. And blame, although as attractive as it might be, isn't useful in solving problems, right? The accuracy of these small facts isn't critical to solving a problem and moving forward. So we want to not argue the details or respond to literal meanings. You also want to not take it personally. We talked before about understanding what your mental posture or role is when you face a difficult conversation. Realize this isn't about you. The difficult conversation is about them and you in your role. And your role as a provider of a service is in the helping role. Whether you are a personal trainer or a massage therapist or a doctor of physical therapy or a sports medicine physician, whoever you are, your role is to help, right? Not to have a conflict with somebody else. It's not about you personally. And I want you to make sure that you're not pandering. What do I mean by pandering? Pandering is validating or approving grossly inaccurate or non-factual ideas, right? So you shouldn't validate a grossly inaccurate assessment without an appropriate follow-on, right? So by acknowledging or apologizing, remember that's the A in AN, you don't want to validate or approve inappropriate behavior or something that is not correct, especially when it comes to boundary crossing behavior. We'll talk about that in just a minute. So prevention of a problem is always better than having to deal with it, right? So heading off difficulty is better than managing it. By communicating well, observing and asking questions, and building an appropriate open relationship, we can prevent conversations from being difficult in the first place. So the first thing to do when it comes to heading off difficulty is to manage expectations. Now, our clients and patients come to us with expectations about what's going to happen under our care. Here's an idea. Maybe ask them what they are, right? You can also check progress and change. And then we will have a serious talk about boundaries and unreasonableness of expectations. So asking is first. So what are you hoping to get out of this, right? Therapy or training or whatever? What kinds of things do you see yourself doing? What's the main thing you think we need to work on? This is my way of helping establish what the expectations are as we get started up front, right? And not only up front, I want to check progress periodically. I want to make sure, hey, are we on the right track here? Is there anything you'd like us to work on that we haven't? Is there anything we're doing you don't think is valuable? These are ways that I have to assess someone's expectations and make sure that the reality and the expectation are as close as possible, right? Often difficult conversations and disappointment are provoked by a difference between expectation and reality, right? And boundaries. It's important to remember, you are not responsible for meeting unreasonable expectations. And you know best in your line of work what reasonable expectations for that encounter are. You are not responsible for meeting someone else's unreasonable expectation. And don't accept words and actions that cross clear boundaries, like disrespect, failure to meet responsibilities on the patient's or client side, or physical violence, patient versus clinician. Now, many years ago, I became the chief of a large physical therapy clinic and asked the staff about what their expectations were and how things were going where we were. One of their concerns that they identified was workplace violence. And I heard this and I thought, oh my goodness, what's going on in this clinic that we're being violent toward each other? And so as I sat down and talked with them, I found that it wasn't the staff they were worried about. It was patients and their families. There was often physical violence happening. Now, let's be clear about what I mean. There were patients and families who were poking chests with fingers, grabbing arms, pushing. I wish I were kidding, right? What do you call it when someone touches you without your permission? That's assault, okay? And so if you want, we can talk a little bit in the Q&A about the sort of things that we did to help fix that problem, right? But physical violence and assault boundary crossing is definitely something where you need to hold the line on. So being proactive and managing expectations is always better than dealing with the conflict when you get there. So let's review what we talked about today. We talked a lot about adherence. We talked about the non-compliance mindset. We talked about this secondary gain thing. And let's put that to bed for real and forever, shall we? We also talked about ways to address someone's concerns through their lens and being relevant and feasible to them to help them adhere. We talked about approaching difficult conversations, understanding expectations, checking and monitoring progress. We also talked about how to respond to a difficult conversation when it happens, how to understand your own mental posture, how to move toward the problem, how to respond to emotions with AN-LOS, and how to move forward together to solve problems and improve both your experience and theirs. So today we talked about difficult conversations and patient noncompliance. I am so excited to be able to talk to you. I look forward to your great questions in the Q&A. And so we'll see you in just a minute. Bye-bye.